Hey, BC here for BC Nephro. Thanks for watching. Today I'm going to talk about hypokalemia, low potassium. Previously, there's another video on hyperkalemia, and we'll provide a link for that. This one, we're talking about the opposite, low potassium. Essentially, how to approach it, how I approach it, how I think about it, the differential diagnosis, and coming up with the right diagnosis and therefore treatment plan. So there's a couple ways to think about it, and it's my structure for most things, renal, especially electrolyte type of things. So one in the framework is there's either too little in, cellular shifts, or too much out for this. Now again, as in hyperkalemia, too little in, very rare, has to be very severe. The kidneys have an amazing capacity to hold on to potassium, so too little in, pretty rare deal. Transcellular shifts. Now we think about the transcellular shifts about what causes hyperkalemia. Now think about the opposite of what can cause hypokalemia, and we kind of know this anyway because our treatments for hyperkalemia are the things that cause the transcellular shift. So there's things like insulin. Insulin either given exogenously for HHNK or DKA, insulin production in refeeding syndrome, things like this. We think about catecholamines, so beta agonists given for asthma, stimulants, high stress or catecholamine states can cause it as well. We think about alkalosis as driving potassium into cells to exchange for the protons, and this will be causing a transcellular shift for hypokalemia. But the interesting stuff in making the diagnosis, where the money is out for most cases, is too much out. So too much out, and there's a couple ways to think about this. And really the interesting thing is you can take each of the differential approach ways to think about it, and you often come up with the same answer via different paths. So one way to think about it is okay, there's too much out. Is it from the kidney or is it not from the kidney? So we think about the kidneys acting appropriately. So if there's extrarenal potassium losses, the kidney should be preserving potassium. So how is that? And the best way to check for that, or the simplest way to check for that, is a urine potassium to creatinine ratio. And if that's less than 13, the kidneys are preserving potassium. If it's greater than 13, then the kidneys aren't and may be the source of potassium losses. So the main way that the main extrarenal loss for potassium is diarrhea. Excessive sweating may be lesser, but the main is diarrhea. Now, vomiting, NG2 losses also cause hypokalemia, but they actually increase potassium losses in the urine. It's not losing in the vomit, and they cause it by potassium losses in the urine. And the reason this is because they cause an alkalosis, and this alkalosis causes bicarbonate to be lost in the urine. The bicarbonate drags potassium with it. So diarrhea is an extrarenal loss. Vomiting is actually a renal loss of potassium. Another way to look at it is the acid-base status. So if is there associated acidosis or is there associated alkalosis? So some of the things, hypokalemia with an associated acidosis, you're thinking about diarrhea. You're thinking about a renal tubular acidosis as part of your differential there. Now, hypokalemia with a metabolic alkalosis, then you have a little bit of a different differential there. So vomiting, we talked about NG2 losses, upper GI losses. Diuretics often cause a metabolic alkalosis, contraction alkalosis, along with the hypokalemia. And then you have the states of mineralocorticoid excess or apparent mineralocorticoid excess, hyperaldosteronism, licorice, things like this. And then you have some congenital conditions such as Barter's syndrome, Gittleman syndrome, Little syndrome. They will cause a hypokalemic metabolic alkalosis. Now, another way to look at it, which should get you the same diagnosis, is what's the blood pressure. So some hypokalemic states are associated with low blood pressure. Some hypokalemic states are associated with high blood pressure. So what's associated with low blood pressure? Well, diarrhea, nausea, vomiting may be associated with low blood pressure. Diuretics may be associated with low blood pressure. Barter's and Gittleman syndrome associated with low blood pressure. What are some of the other ones associated with high blood pressure? Well, the states of aldosterone excess or apparent mental quota excess, which would be the primary hyperaldosteronism, glucocorticoid remedial aldosteronism, and the apparent mental corticoid excess states. These are going to be associated with high blood pressure as well as Little syndrome. So this is an approach that I take. Different approaches you can take. You're going to get to the same diagnosis. You can confirm the diagnosis by different pathways. So if you want to learn more about this, there's a link below to bcnephro.com where there's an article on this. Email me at brian@bcnephro.com or comment below with questions, comments, other topics that you want to hear about, you want videos about. Until next time, thanks for watching BC Nephro.